Okay, so good evening, everybody. Good night. I know this is the last session of this conference. I know, of course, maybe a hard task to speak to people in the last session, in the last day, after a long day. Of course, maybe. But my mission will be more hard, so I have to summarize what is the most important in the last ESMO, just a few days ago, about metastatic breast cancer. We have many sessions in the last ESMO, about 2 weeks ago, about metastatic cancer. I'm trying to collect the most important data, and I try to even to present some slides as such as was presented in the ESMO, so forgive me for the quality of the slides. One of the most important sessions is about integrating longitudinal strategies into the management of metastatic disease. Whether to treat or not to treat, what about oligometastatic disease, what about the local treatment for metastatic patient. In this study, ablative therapy, mainly in the form of stereotactic polyarray therapy for metastatic disease, what about synchronous versus metabolous? Those patients presented with metastatic disease versus patients who developed metastasis later on, and the progression-free survival were almost the same. This study is SABR, COAT, eligibility criteria including patient more or less about the definition. So the definition of oligometastatic, including patient with primary tumor control 3 months, with no progression to the right side, up to 5 metastases, and maximum 3 hits in a single organ, excluding this with brain only on organ progression. The primary endpoint was overall survival, and second endpoint was progression-free survival and toxicity endpoint of life. Updated overall survival and progression-free survival both were positive, and regarding time to new metastasis, no significant difference. But comparatively, short progression-free survival benefit in the context of non-overall benefit suggests that post-progressive treatment may enhance overall survival. Meaning that most of these patients responding and then progress, but further lines of treatment will lead to overall survival. Another trial, NRG-R002, with a median progression-free survival 19.5 months for the group receiving SBRT plus standard of care versus 29 months for the group receiving standard of care along with SBRT. But there is no difference in the survival, and still there is a trend in favor of SBRT in relation to more than 1 month. Another trial called this randomized trial for conventional care versus radioablation, stereotactic polyarray therapy in extracranial oligometastatic disease. The median progression-free survival for the whole was 25 months for the group receiving SBRT versus 20 months for the group they didn't receive. And this is the progression-free survival, and the first one in the conclusion was, despite the lack of real-world evidence, still SBRT has become an acceptable treatment option for oligometastatic disease. Where does this leave the role of SBRT in oligometastatic in 2023? SBRT is still in commission for the use of metaconus oligometastatic disease up to 3 months, according to the presenter in this talk in the UK. But still, there is some conflicting data from the randomized clinical trials regarding progression and overall survival. But in the following, we should follow the following rule. Start systemic therapy almost before SBRT. Successful completion requires SBRT to all lesions, even in what's called spot multiple lesions. Excellent local control of the 3 trials, quality of life is good, and of course, we found that SBRT less than 1 fraction to 12 fraction for most of the systemic treatment. This is the SBRT line, which usually don't tell you what's exactly to do, but consider. Consider the site of metastasis, consider the management of the primary with the axillary, consider systemic treatment, development response, and consider local therapy. So many patients with metastatic lives alone, systemic therapy are doing a good job in their own. CBRT may improve progression-free survival and even overall survival, but still more randomized trials are needed. Realization of CBRT survival benefit may require ongoing ablative approach. Again, CBRT is associated with excellent control with good quality of life, and more randomized clinical trials are needed. Last point is very important. It's improved methods of cancer detection. Many talks in the last ESMO and even in most of the last studies about the circulating DNA and its emerging role. And so I think it will play a very important role in the next few years. According to the presenter, what I do in the clinical practice in this country, UK, look at treatment of the primary patient with metastatic disease. Yes, if only metastatic for durable local control. Generally, not in patient with widespread disease unless if there is a local advanced disease or RBC, inflammatory dislocation, and bleeding and so on. Local treatment for the metastasis, yes, if metacrons or test up to 3 for local control, if nothing else. In the country, they saw that SBRT is not covered by in the synchronous metastasis. But of course, this is not applied for hair-positive disease, it's not difficult. What about brain metastasis? Local treatment for brain metastasis. Of course, try to avoid whole brain therapy as much as possible due to its bad effect on the cognitive function. Medical treatment for brain metastasis, yes, from the old trials, academic, trastuzumab, capecitabine, and nowadays DXd with 14 months of overall survival. Sorry, progression of survival. This is the ESMO guidelines, and we have to post it, and we can realize that it's now dependent on the second line presence of active versus non-active brain metastasis. So the patient will be divided among the presence of active versus non-active or unknown or absence of brain metastasis. And this is because of the effectiveness of the systemic treatment like tucatinib and TDXT and the brains. When should we use medical treatment for progressive brain metastasis? When there is nothing else. When you have a good chance for being active. Okay? When you don't want to use whole brain radiotherapy, and when progression is associated with no symptoms or few symptoms, with aggressive systemic disease, especially if there's hair-positive disease. Isolated brain metastasis, another question. How many times have been asked? Isolated brain progression, accessible to local control. Should we change the systemic treatment? Usually, we say no, don't change. And now we have the evidence from these 3 trials that the progression-free survival is possible when you continue the same treatment for the systemic disease if you have isolated brain progression. Integrating low original and systemic therapies for CNS, both with local treatment must always be preferred when possible. Moderate surgery and stereotactic therapy are very efficient with good quality of life, like I mentioned, and medical treatment, especially for chemosensitive patients like those with hair-positive disease with some agents. When does metastatic disease benefit from local therapy? Local therapy indicated in brain mets, symptomatic for palliative surgical radiation, locally advanced results. Not indicated in asymptomatic or pre-systemic intervention, not indicated in diffuse progression, not indicated in primary tumor therapy with daily stage 4 disease, but still indicated regarding electromeningeal disease and oligomenistic disease with durable response to treatment. This is the ESMO guidelines again for metastatic patients, and usually not indicated to do or not to do primary research and radiotherapy in metastatic patient with breast cancer. All the trials the trial didn't mention the overall survival except the Turkish one, which favored overall survival when using local treatment for metastatic patient. Again, surgery and radiotherapy for primary tumor in diffuse stage 4, local regional progression favors treating the breast locally advanced or symptomatic only. But if there is any overall survival, no, there is no effect on the overall survival. Finally, multidisciplinary care helpful in symptomatic local disease. However, this is uncommon. We said that about 25% of IBCs are being presented in stage 4, and if there is an adverse symptoms, we may need this surgery rarely needed. Again, this is the definition according to ESMO, up to 5 lesions, and this lesion should be amenable to local treatment and responsive to treatment, and we should classify either the full or the on initially onset or after treatment. This is the trials in treating oil metastatic osteoarthritis intent and multiple uncontrolled series suggesting improved outcome with local treatment. Again, there is the guidelines. Consider these lines mentioned on solid tumors in general, and regarding the patient with risk, the hazard ratio for those receiving local treatment 1.77 means there is a good benefit of local treatment. Basically, we should involve multidisciplinary team in symptomatic and serious involvement in neuro-oncology. Systemic therapy is primary, all is, and of course, to support more randomized clinical trials. Another presentation in ESMO 2023 about optimal sequencing of the study cancer. Optimal sequencing in human and metastatic triple-negative. In human, first line CDK is always the first. Another question, can we use CDK after CDK? Another question, in the second and third line, still the plastic therapy has an option or have been absolutely replaced completely by ADCs? And final question in the luminal, should we do the mutation testing for completion regarding a positive disease in the first line? Still, there is more for classified pertuzumab or an alternative in the first line. In the second line, we would use TXT and we would use tucatinib. In the third line, what is the preferred option? In the metastatic and the negative in the first line for PD-L1 positive and germline recommendation positive, BARB first or immune therapy first. In the second line, EDC, sensitive or TXT, which is the best option. And again, to test the mutation germline, or we may test another mutation. A very important question was raised in the ESMO: can we use somatic mutation BRCA in breast? And there is a trend nowadays that we may use somatic, not only germline, maybe like the ovarian cancer. In the human trial, how to make the best choice towards the decision, prognostic assessment, decision biomarkers, of course, AR, HER2, low versus 0, germline mutation, PIK mutation, ESR1 mutation, and don't forget to do biopsy, because about 16% may have a change in version from survival. 2/3 of them may lose hormone receptors, and about 1/4 of them they lose hormone receptors and gain HER2, and very few may lose HER2. So, can we add for the decision functional assessment? Again, the assessment of circulating tumor DNA to assess for some mutations like ESR1, and can we base treatment on that? Yes, according to BALA-1 trial, we mentioned it. Can we use CDK in the first line? This is the standard, as we know. Can we use it in the second line? Yes, according to the Sonia trial, and this trial was, I think, funded by the Netherlands Health Authority to test whether it is beneficial to use to delay postpone BARB or CDK to the second line. Yes, it was positive. Although the benefit in the first line of was more obvious, but still it's beneficial in the second line. How targeting the estrogen receptor level resistance? ESR1, ESR many trials. And can we change the right backbone while maintaining CDK? Yes, according to the maintain trial, the population survival is significant with ribo, but unfortunately it was not significant with ribo. Can we change the right backbone while maintaining CPK before clinical progression, and actually, this is a very interesting trial with a very good result. In this trial, they don't wait for clinical progression. With the appearance of ESR mutation in the circulating DNA tumor cells, they shift to fulvestrant, and results were significant, but it is not yet standard. Can we target ESR mutation from the start? And this is the evaluation trial. It is strand, which is an oral SERD, and oral SERD versus standard therapy, it was positive. Again, targeting big act in tumor pathway through the SORD study, capital study, immune study for IBCD, carry, and electronics. Targeting HRD, meaning the use of PARP inhibitors in germline like a carrier, can be considered in the later line is according for both oral and transferrin. And what about the second line? All these trials using fulvestrant alone, fulvestrant GLC, with carry, fulvestrant or to use elacestrant, the oral SERD, all these trials with a good duration of these trials. Coming to the era or the fashion of ADC, I think this is most of the work presented in the ESMO and all any other conference about breast cancer will be about the effect of antibody conjugate using the approved one, trastuzumab deruxtecan, or trastuzumab and most trials were analyzed with autologous condition. Decision are partly decision based. Okay, and endocrine CDK combination is a standard first line, of course. Second line CDK, post CDK is not a standard yet. Second and third line chemo shall include HER2 or HER2 targeted ADC. What about the second post in the first line? Is still trastuzumab taxane in the first line, the standard of care with Cleopatra, either docetaxel or paclitaxel. In particular, assessing the effect of adding pembrolizumab to the hormonal therapy, to AR, plus trastuzumab, which is HER positive and ER positive, and the trial was positive. This is the ESMO guideline for the first line therapy in HER2 positive. What about second line? TDM1, according to the Median study, is approved for second line versus capecitabine. And now we have the new label, maybe the new, I should say, whatever, the TDXT, trastuzumab deruxtecan, comparing versus TDM1, of course. Updated overall analysis of this breast OC showing that it is positive and it has a ratio 0.64, which is a relatively very good figure. What about tucatinib, which is a very potent and selective inhibitor? Being selective means decrease the effect of EGFR related toxicities. And also it has a very advantage of penetrating the CNS, so it has a very good activity on the brain metastasis. The HER2 trial assessing tucatinib plus trastuzumab capecitabine versus placebo trastuzumab capecitabine, and the result updating overall survival results in patients with active brain metastasis is still good results. So this was approved approach therapy for metastatic positive, and we can see that the patient having active CNS metastasis start with tucatinib. Okay, to be followed by TXD. If there is no active premise, start with TXD to be followed. But in the red box, what about TDM1? It's an unanswered question. The use of TDM1 after TXD. What about the addition of tucatinib to TDM1? It is possible regarding the progression-free survival, but overall survival data not enough. So another modification, we have now 4 lines. 4 lines is positive. Okay? And again, what about the TDM1 after using the TXD and tucatinib? So what about the answer question is still what is about the efficacy of TDM1 after TXD? Is there any role for another TKIs like military or peritoneal, especially patient receiving tucatinib before? And what about the efficacy, comparative efficacy of BCC versus tucatinib in brain, which to start with. Till now, to start with tucatinib. Till now, most of the guidelines. But a very important question regarding patients with metastatic head disease. These patients till now are treated palliatively with very good effect of these new medications. Can this patient, can we take that with this patient curatively? This trial has two sides to assess the percentage of patient progression-free survival at 4 years, at many lines. So there is a concept about treating the patient with metastatic HER2 curatively, not only palliatively. What about metastatic breast? This is the standard that we know metastatic triple negative. This is the chemo 355, all of us know, or the use of immunotherapy and PD-L1 expression. And this is all the data about Impassion 130 or Keynote 355. Patients with triple negative BRCA, as we know, with triple negative, okay, about 11% in the early and about 13.4% of the metastatic patients had BRCA mutation. This is a very important question. When I go to ask for my patient about BRCA, she's going to ask me, how many treatments you expect to have? What's the percent expect me to have this mutation? If she's early, about 11%. If she's metastatic, about 15%, and most of the time, more than 15%. This is the Olympia for ovarian, and this is for BRCA for plasma. All up for germline mutation with negative metastatic breast cancer, and still with a lot of Viva, yes. Still there is a lot of Viva, although they are conflicting data, but many trials address the role of Viva in metastatic triple negative. This is a multi-action therapy, as you have out of time. Saxagliptin, I think the protein, phase 2 trial, it was positive versus the standard of care chemotherapy. And yesterday before, regarding, we just heard about the last presentation about HER2 low. So it is HER2 low is part of triple negative, and we can use it, of course, in triple negative. And to summarize, PD-L1 generalized deletion must be done, of course, and to concentrate on the ADCs, TXD, and CESPTCAN, and new drugs. This is last presentation, which was very nice about the future of triple negative. The topic was what is positive in triple negative. Search for the positive in triple negative. Sorry for the part slide because it was presented like that. We have searched all the markers that could be positive in triple negative, including androgen receptors. We can classify androgen receptors positive or negative. If it is negative, we will be also prognosis, and we have a new class we call quadruple negative instead of triple negative. It's a fraction of triple negative that may contain negative androgen receptors. Also, HRI testing, germline mutation, and germ-BAL and others. In big emitter mutation, we have approval in this pathway in the lumen, but now we are trying to use it in the triple negative. If the pathway method use big inhibitors, and you can act inhibitors only and emitter inhibitors if we want. Also, inflammatory type for the immunotherapy. The summary of what is tried is concentrating on the molecular techniques. How can we assess the response of triple negative before starting the treatment? How can we use a very complex because a very huge amount of data. So, starting using the artificial intelligence and what's called machine learning. How can I learn the computer system to get all this amount of data to get me this patient, this particular patient, will benefit and triple negative of such treatment or not? And this slide was a conclusion with therapy especially suited with response, integrating genomic data to predict HRD, integrating immune repertoire sequence to develop personalized metastatic breast cancer immunotherapy. Breather genomic landscape that preclinical trials is associated with response. Another point was mentioned, why we develop resistance to PARP inhibitors. This patient, she carries germline mutation. Why she developed response, initial response to olaparib and trazparib, and then after a period of time, they develop resistance. This is because of the validated cause of homologous recombination. This methylation and clinical barrier inhibitor resistance occurs via second hit fixing. Second hit fixing of the pathogenic BRCA1 and 2 alleles, what's called reversion mutation. Reversion mutation is the BRCA reverse itself driven by alternative way. So the patient started to lose the marker that are working upon, so she developed resistance. And if it is detected before treatment, usually the patient develops resistance not only one to one, also to collateral imbalance. To summarize, BRCA1 and 2 allow mutations are possible in HRD selection or marker for barrier inhibitors. Breast triple negative, it's common, more than 50% of triple negative. The presence of other treatment condition, BRCA1 and BRCA2 methylation. This is the process by which we lost the brackets, the process of methylation. And so we have to search for it because it reflects the germ-like mutation, and so this is the cause of resistance. And if we can detect it early, we may suspect this patient. This patient in particular will not get so much benefit of the barrier inhibitors. This is the new target seeking for the triple negative, ACT inhibitors. All of these possible data, the state most example 1 and 2. What about the big inhibitors that are sleep in triple negative? Again, ADCs, Sacituzumab or Trastuzumab in triple negative, or in, of course, the TXP inhibitor. Now they talk about to shift from India to in the first line, to use this not on the second line, but in the first line. Okay, another new agents active with the TOP protein, and now in the phase 1 and phase 2. Okay, can we first use the first line? Says the first line. This is the new agents, radically, and new targets like active HER3, we just mentioned, like HER3, Nectin-4, and B7H4, which is a transmembrane protein. This is preclinical data about these new molecules, maybe in the future. All these targets in the future will be active about triple negative, inshallah. Thank you.
Professor Dr. Hani Abdulaziz, طبعا thank you very much. دي وجبة دسمة جدا وكل اللي ما حضرش باسمه نزل عليه دلوقتي برين ستورمينج ايه ده كله على ايه يعني فعلا يعني we have a lot of questions for myself about origometastatic and circulating tumor cell لكن هستأذن حضرتك عشان يشاركوا معانا أستاذ الدكتور أحمد شاش ومحمد صبري لأن مفيش كتير قوي من حضرتك ممكن keep the question يعني الجلسة ظريفة ومش مستعجلين ولا حاجة بس okay. This is now my role and my honor to present دكتور عماد شاش. دكتور عماد شاش هو سينيور مدرس في معهد الأورام. بس احنا بنعتبره أستاذ الدكتور عماد شاش لأن الحقيقة احنا ألقينا عليه مسؤوليات أكثر من أي أستاذ. فهو مدير مستشفى التجمع أكثر من 3 سنين وعمل طبعا فيها بروجريس رهيب. نتمنى أنكم تزورونا. دكتور عماد شاش one of my best students through my life. He is very dedicated, very meticulous. He after cancer registry and cancer data. دكتور عماد اتفضل في ظرف 20 دقيقة القادمة هتقدم لنا what's happened and what's advanced in the advanced
يعني شرف لي دكتور عماد ان حضرتك تقدمي يعني انا اشرف ان انا اكون تلميذ لحضرتك يعني بشكر حضرتك على التقديمه ويغفر لي في سنون اللي انا بقى هنا مع ضمن يعني مع اساتذتي في عين شمس دكتور ناس العرب وكل الاساتذه وبشكر الدكتور محمد صبري القاضي على الدعوه هو والدكتوره هاجر على ان انا اكون part of this session. يعني عارف ان احنا at the end of the day, but however what I will try to make is to clarify a little bit. Dr. Hani had highlighted a lot about the triple negative breast cancer in the advanced stage. So breaking barriers is the slogan for what we are assuming that the metastatic triple negative. This is my disclosures, but not for this presentation. So the agenda of the day, I will try to pass in more of what we have in terms of the metastatic PMDC, the introduction and the principles of management. I will highlight and summarize for the PARP inhibitors, the immunotherapy, the antibody drug conjugates, and then finally with a conclusion and take-home message. So what we know that the triple negative represents approximately 15 to 20% of all breast cancer. But uniquely, what we need to understand as well that the TNBC are patients who are generally younger and the overall population, but actually what we all do that it's an aggressive biology and we have a relapse pattern that it's short disease-free interval and there is increased incidence of visceral metastasis and as well as CNS metastasis. So this is the burden that we have. What we used to do is actually to have a sequential and we use the single agent chemotherapy is the preferred approach. Combination chemotherapy can be used particularly for patients requiring more rapid response but does not improve the overall survival. So that's what we know. And that's actually what we all do in the metastatic setting is to go one sequential after the other. So single agent is the preferred. We do the treatment until disease progression or unacceptable toxicity, more or less up to 3 lines of performance status, more than 3, then best supportive care is the ultimate part. So the consolidated facts that what we have shifted in the past 10 years that yes, it's an aggressive biology, but it's not a single disease. It's a heterogeneous disease, and we need to think and see clearly how we can tackle this from the biology. So better understanding of the biology can definitely revolutionize the disease outcomes. So Dr. Hani had highlighted actually more and more of what we have, but the most of the standards and what we have is actually the PARP inhibitors for the basal, like for the germline recommendation. That's the approval, the immune checkpoint inhibitors for the immunosuppressive TNBC, but definitely for the PI3K inhibitor for the mesenchymal TNBC, and as well there is data about the AR antagonist for the luminal hypercrine part of the TNBC. So we have increasing armamentarium, but the question is actually how to optimize the usage of for better patient outcomes. First line or subsequent lines, we need to look into the primary endpoints of the trials that are the evidence, the progression-free survival, secondary endpoints, overall survival definitely, but safety, tolerability, and quality of life reporting. So actually, with this is the first to come into part. The PARP inhibitors will not go into details, but it's actually having a normal DNA repair, and this is an enabling hallmark of cancer. So PARP inhibitor was there, but we know that in the normal cell, in the presence of the PARP enzyme, the base excision repaired by the single strand fixed by the base excision. But if there is a PARP inhibition and the BRCA is intact, BRCA1 and BRCA2 are intact, it can still do the repair by the double strand repairing mechanism, that is by the homologous combination. So particularly in those who have a BRCA mutation and actually have a PARP inhibition, then there is no single excision and there is no double strand, and that will result in the tumor cell to die. So this is the structure of PARP inhibitors in the clinical development. We all know about them. The most for the TNBC is actually the olaparib and the telazar. So recommendation in breast cancer, approximately 5% of all cancer patients having a recommendation, and that's why we need to be vigilant and to try to seek optimization. So who and when to test for BRCA, it's definitely according to the SCN and the SBRCA. Those younger patients, as elaborated very clearly by Professor Miguel in their presentations. Those who are 45 years or younger are eligible for having the BRCA mutation testing. Those who are 50 years or younger having additional breast cancer or have a family history criteria should be tested as well for BRCA. Those who are 60 years or younger and they are TNBC, and that's even people going more rapidly to rule that all TNBC should be subjected for BRCA mutation. But as well, any age group having ethnicity associated and having family history then can be offered by the genetic counseling for the BRCA mutation. So, Olympia was the first trial to have the proof for those who are BRCA mutated TNBC or HER2 negative, that means that they are hormone positive, to be randomized in a fashion of 2-to-1 to collaborative versus the treatment physician choice. And the primary endpoint that we need to look carefully, the primary endpoint is the PFS. And definitely, the collaborative showed that it can increase the risk of progression for the improved progression-free survival. So that's what we know. However, again, secondary endpoint was OS, and Olympia was not powered, and it didn't show at the final cutoff for the OS. So this is what we have in curves. But then, what we know of the piece of information that this trial included the hormone positive, HER2 negative, and the TNBC, but clearly the PFS was magnified, the magnitude benefit was in the part of the TNBC, and that's why if you are pushing the part inhibitors, mainly the TNBC is the place for this part. The consistent PFS was observed as well in patients who were treated by prior platinum, and that's what we knew, that it tends to use the platinum more into the neoadjuvant now, and that's meaning that if you are using it in the neoadjuvant, then part inhibitor is still working for those who had received previously platinum in their treatment. Definitely, again, those patients who didn't receive prior chemotherapy may have an increased overall survival. So the safety profile, nausea, vomiting, and as well the anemia and the fatigue, these are the side effects that you need to take into consideration. But definitely, using the PARP inhibitor will have time to deterioration of the global health-related quality of life will favor in terms of collaborative. So that was the Olympia in BRCA on a similar study design with the tabazzo versus the standard of care at that time, the capecitabine, the physician chemotherapy choice, the capecitabine, gemcitabine, or whatever it. And definitely what we have observed is more or less similar progression-free survival, and the subsequent showing as well that there is here a slight difference of both the TNBC and the hormone positive responded. But again, the final OS for the PARP inhibitor was not observed for this, and that was a pre-specified analysis. So the PFS subgroups, what we can see that every part of the PFS subgroup is being there. However, in particular, for those who are having a CNS metastasis, then there was a slight activity for the endoscopy in this group. So this is how you differentiate PARP. More or less with the similar adverse event like olaparib. So taking into consideration as well that PARP inhibitors counts with an expense of some safety that we need to observe. However, the quality of life again in comparison to the chemotherapy is in favor of the PARP inhibitor, and as well the time to deterioration. So this is reasonable to see a repetitive message for them. So this was the base to have the meta-analysis for the phase 3 trials of the PARP inhibitors, and definitely again this is confirming that it's in the fact that you have a germline BRCA1 or 2, you have the effect on the progression-free survival. Numerically, you will have also the less survival. But that's having the fact to say that PARP inhibitor is working and increasing the response rate, and that's even better than going into chemotherapy for this. So conclusions, what we know for the PARP inhibitors, that definitely is FDA and EMA approved, and that's why in the metastatic TNBC who are having harboring germline BRCA mutation 1 or 2. So for the immunotherapy, for a long time we used to think that breast cancer is not immune. immunogenic. However, if you take into consideration, it's in a moderate immunogenicity. However, when you combine it with chemotherapy, this is the fact when you have inducing the multiple immunomodularity changes in the tumor microenvironment, and that may influence the effectiveness of the immunotherapy. So 3 trials assessed the addition of the immune checkpoint inhibitors, and there was no prior therapy for blood cancer. That means that the first line therapy with the Impassion 130 that had the first 3 out, then the Impassion 131 and the Keynote 355. And the Impassion 131 was using the immune checkpoint inhibitor in combination with the nab-paclitaxel, which was not available in every part of the world. However, it was very interesting when we had this in the ESMO 2019, and the following publication by Peter Schmidt that showing that it works in the intent to treat, however, the maximum of benefit in the PD-L1 positive for the addition of the atezolizumab plus the nab-paclitaxel. The final OS as well was in favor of the immune checkpoint inhibitors in the PD-L1 positive, and that's here you have an OS survival with the immune checkpoint inhibitor. Unfortunately, with the Impassion 131, where you allow the paclitaxel, the more you utilize the chemotherapy on banding versus the paclitaxel, but we have seen that the trial didn't meet its primary endpoint, and that was a negative trial. And that was actually the basis for Roche to withdraw its progression on the development of the nab-paclitaxel PD-L1 immune checkpoint inhibitor, and to have the TISU to be withdrawn from the marketing authorization. Coming back for the immune checkpoint inhibitors with the Pembro, the Keynote 355, which also have a similar part, but there was a safety portion that integrated the Pembro plus the nab-paclitaxel or the paclitaxel or the gemcitabine carboplatin, and that means even having a combination of chemotherapeutics. And then when having this, it goes to the part 2, which we all know about, is the Pembro plus the treatment choice with the nab-paclitaxel, paclitaxel, or gemcitabine carboplatin. And the Keynote 355 has a specific primary endpoint, which is the dual primary endpoint, that means of the progression-free survival and OS. And here to highlight that it was depending on hierarchical testing. That means that the PFS superiority need to be positive in those who have combined scoring of the 10, as well as the OS superiority. And move to the PFS superiority in the other subgroups, it means that you need to have a PFS superiority in the pre-specified hierarchical segment. And clearly, the PFS in the PD-L1 of those who are combined positive scoring more than 10 was clear in 65% versus 49% of events, and that means that of the median progression-free survival was 9.7. And as well, it was positive in the intent to treat. However, when going into more details of the PD-L1 combined positive scoring of those who are more than 1%, the magnitude benefit is not there. So definitely, if you try to understand as well, those patients who are having a free time with further more than 12 months will be responding as well for the combined positive scoring more than 10. So clearly, and what we have seen that the FDA granted accelerated approval only in those who are PD-L1 positive, combined positive scoring more than or equal to 10. And as well, in the final analysis confirmed that was recently presented as well in the ESMO 2021, that the combined, there is a maintained benefit for those who are combined positive scoring more than 10, and as well for the other words, even if you can consider that the combined positive scoring more than 20, this is more of a logic, then those patients would respond more. So it's very crucial for the TNBC to get for the having the PD-L1 positive scoring. So that's what we need to know in terms of efficacy. However, in terms of toxicity, what we need to take into consideration that it also counts with an extent that we are more of now knowing more of the information about the immune-related adverse events, the hypothyroidism, pneumonitis, all these we need to take into consideration. So finally, into the antibody drug conjugates, and that's very unique because this is how the era will start. We embark on the immunotherapy, and I guess that now we are embarking into the era of the antibody drug conjugate. Dr. Henry had highlighted this, but it's simply a monoclonal antibody, and to be linker, stable linker, or to have a potent cytotoxic payload. And classically, what we have understand as well, and that's very important, is the bystander killing effect. That means it's not only in the cells that it is attacked, but also in the neighbor body cells, and that's the addition of having this for the bystander. So we have different parts, but we need to understand that they are different in terms of the linker and in terms of the payload. So this is the differentiation between the different antibody drug conjugates. The TROP2, one of the Dr. Henry highlighted, is a therapeutic target, and it's targeting both expressed markers, but it's the TROP2, it's a pan-nuclear cancer antigen. And cetuzumab govitecan is the first in class TROP2, where here is the bystander in the acidic tumor environment, and that means that also it is well diffused into the neighboring TROP2 negative, so not only for the TROP positive, but also for the TROP negative part. And it was developed, and actually the ASCEND trial is those trial patients with metastatic receiving more than 2 prior chemotherapy. That means that they are at the end of their treatment to receive the antibody drug conjugate versus the physician choice, with the primary endpoint PFS and secondary endpoints as well, including the OS and the disease response and the time to response as well. So PFS and OS among patients without brain metastasis was there for the patients receiving the antibody drug conjugate, and as well this had been shown in the HER2-low, but here I have to say the destiny that the HER2-low is either those who are scored 0 or 1 or 2 plus negative on decision. And then the trial of the destiny, which was initially for the HER2-low, and it was positive in terms of those who are hormone positive and disease, there was an exploratory analysis that was done for patients on who are hormone negative. It's a small number of patients that will into the destiny before, but this is a proof of concept that again the TDX can work as well for those who are hormone negative patients. So in conclusion, and for the take-home message, I guess that there is a shift in the treatment of the metastatic TNBC. We need to assess if this is a rapidly progressive visceral disease or not, to be either with combination chemotherapy. If not, we need to go and identify if those are BRCA, and definitely if there is a yes, then we need to check what the prior chemotherapy that have been given. And again, you need to check as well does the tumor express the PD-1. I guess that we have 2 options. However, we need to understand that those options with the immunotherapy have as data. This is a conclusion, and this is the question as highlighted by Dr. Hayden. If not, then the tumor expression is does it have PD-1, then checkpoint inhibitor is the only one, and then this is if not with the single agent chemotherapy over vaccine. So if the recommendation for clinician is no, then we will ask the same question: is it having the PD-1 combined positive scoring more than 10 or not? If not, single agent. And I guess this is what we have as of today, and thank you so much for your time and listening.
Thank you very much, Professor Ahmed, for this very clear, elegant, and very comprehensive talk, as always expected from you. I think we'll strong information at the end of the session. And now I invite my new friend, colleague, Professor Mohamed Sabri, one of the shining stars in oncology بصراحة. أنا بالنيابة عن كل الكل بشكرك على الكومنتس الجديدة والسنة اللي بتعملها على الفيسبوك. فيري informative and very important and achieving the beyond senior oncologist.
Really appreciate it, Dr. Kamal. Really appreciate it. Thank you for your introduction, and I'm happy to be with you. It was a very long day of very heavy meal of information. I wish we خفيف عليكم لكن الوجبه تقيله فعلا. هنتكلم على more than 30 phase 3 trials in process inhibitors. That's why I want for my talk today to change from the reading to read practice. That's why I put technical cases for discussion for the patient receiving C4 and sequencing of treatment. That's why there is no head-to-head trial between C4. That's why it's a very good job, hard job to compare, because there is no compare trial between C4 till now, or the comparison in the level of phase 2 trials. Till 2014, as Dr. Shahan said, there is no children practice till Cleopatra trial said that dual application of chemotherapy improving OS survival benefit for the patients. So, till the 55,000 years women shared in the 9 main trials, the Promus and Blazes and other trials, they changed the practice from 2015 to from AI to process combination either with AI or investment. That's why we changed our practice from AI, investment, cross-sensing single agent to combination with C4 either ribo, or palbociclib. This change in practice started from 2012 by M2 pathway for C4, then big 3 medications, and we are now in the era of oral investment or selective estrogen receptor degradators and antibody drug conjugate and cetuximab in the end of treatment journey for the patients. So, if you have deeply understanding the initiation of the trial, you can explain why some trials fail to have OS benefit and other trials waiting for results. Because if you see that the palbociclib started from 2015, they have 14% method of follow-up for the patients. That's why they can go for more follow-up with the patient, because they lacking of patients. So they have no further OS benefit for those patients. And abemaciclib, the last C4 child in the journey, they are still waiting till now. Till next month, you have a mature OS benefit for abemaciclib plus fulvestrant I as the second treatment or first treatment. That's why we have the ribociclib started early and keeping following the patients till now, and we have from the 2 trials we have 7 years of follow-up for the patient receiving ribociclib and plus AI, or these 3 trials receiving ribociclib plus fulvestrant. That's why when they follow their patients, we have mature OS benefit for their trials. So if you are, it's not comparing between trials, but if you explore barometric and trials and other 3 trials, you will find all of these are effective and have the ratio of PFS for the whole population, but they are not the same for the overall survival benefits. They have lacking OS benefit except ribociclib with AI or fulvestrant, keeping with all that. So the question now is, which C4 inhibitor should be chosen? The OS benefit is the most attractive point to be highlighted by
any investigator, because it reflects actually the PFS. But PFS may not reflect OS benefit, because the patient may have improved PFS, but OS benefit is immature, because simply when you are tracking OS benefit, you are tracking the patient from randomization till death. So the drug giving OS benefit in the drug and post-treatment failure. So by mature OS benefit, you have PFS1 improvement and PFS2 improvement. So the ideal goal for any investigator to have OS benefit for their drug. So ribociclib till now is still the drug of choice. If you are searching about OS benefit, the ribociclib plus AI or plus fulvestrant, maybe abema next month will be with AI for Monarch 2 trial to be highlighted in the guidelines to be OS benefit, but it's still waiting because they are still waiting for more surviving and more events, more death to have a mature OS benefit. But for Palomas, they're lacking for their patients about 3 years ago. So in ASCO 2022, that's last year, they put a 20% improvement of OS to be evident. We can see that's a combination of ribociclib plus fulvestrant or ribociclib plus AI, and also abema plus fulvestrant has touching the 20% of benefit of CD46, either first line or second line. That's why OS benefit translated to ribociclib combination either with fulvestrant or AI as first line or second line treatment. And we have now 1 year improvement in the OS benefit for the patient receiving ribociclib for more than 7 years with visceral or body metastasis. That's why when you are tracking your patients well, you have a mature OS benefit. When you're losing your patients, you lose OS benefit. So in last NC guidelines, we can find that ribociclib plus AI is category 1 recommendations for the patient receiving first line treatment and also second line treatment. So that it means ribociclib combination for all comers. Actually, the benefit is controversial because not the trials powered enough to answer the question. And there is no cross, as I said before, between trials comparing CD46 by each others. And also the design of trials is totally different between trials because we can see that Paloma 3, they including primary resistant patients. They have given a previously chemotherapy for these patients. It's not allowed by any trials. And also they lost follow-up during 19 months of the trial. That's why this is exploring the Paloma 3 and Monarch 2 and Monarch 3 trials for a second-line treatment. You can watch that Paloma 3 included patient receiving prior chemotherapy, which is not allowed in any trial in Monarch or Monarch 3 trials. And also, those patients with Paloma 3 trials, including patients with premenopausal and primary resistant patients as Monarch 2 trial. So we have now the 3 elements, abema, balbo, ribociclib, to be combined with AI or fulvestrant or second line or first line treatment. So the MDT decided to go for CD46 plus AI. هي بتكتب كده بالفعل CD46 without naming, and the prescription come for pharmacist. Ask the physician which CD46 you kindly prefer. He answers the same hazard ratio. Give the CD46 available. This should not be the practice in our daily practice because if you have no head-to-head comparison between CD46, you should tailor your choice upon drug efficacy and also drug toxicity. So in the last year, this published very elegant data about how to consideration of first-line treatment of CD46 based upon drug toxicity. That's why discussion of treatment, comorbidities and drug toxicities and drug interactions may tailor your choice with the proper first line or second line CD46. That's why we have a drug-related toxicities, we have a patient-related comorbidities, we have inflammatory bowel disease, maybe the abema is not a good choice for those patients. Patient with arrhythmia, the ribociclib may be a troublemaker for those patients. Patients with neutropenia, palbociclib may be not a good choice for those patients, especially with bone marrow filtration. So the toxicity and the comorbid illness make you tailor your choice about the proper CD46 in the first or second line. Isma, for my first case, is 14 years old, premenopausal, newly married female. She was diagnosed 5 years ago to have T1 in node M0, carcinoma grade 2, ER positive, PR positive, HER2 negative, K7 10%. She had a lumpectomy 5 years ago, and she finished her term with no ovarian suppression because she wanted to have a chance to gain a pregnant. 2 years after 5 years of adjuvant, after 7 years from the initial treatment, she have a rapidly progressive disease. As you can see, that she has a massive left pleural effusion. It's a real case with multiple bone metastases. The broad biopsy confirmed that she has a recurrent disease with still ER/PR positive, HER2 negative K7 30%. This is, you can see that the patients have a massive left pleural effusion. Maybe the patients cannot lean forwards, and she has orthopneic and start to have a hypoxia. The decision is to go hospital for tapping. The treatment choice of to give her chemotherapy, consider her as in visceral crisis, or to give her hormonal treatment as CD46 inhibitor plus ovarian suppression. Concerning, this is not a visceral crisis because the patient is stable, it's not hypoxic, and the pleura is not a visceral disease like lung mets or liver metastasis. So she has a pleural disease, no visceral mets, just bone metastasis, but she has a rapidly progressing disease, need a treatment of rapid response. The chemotherapy is there, and the hormonal treatment also is there. She started by ovarian suppression, by taking LHRH analog, but in this case, I gave her LHRH antagonist to have a rapid response or rapid ovarian suppression, and the choice for your choice to have ribociclib or palbociclib or abemaciclib. I have the answer. Because we have, if you are taking the MONALEESA-7 trial dedicated for premenopausal women, you have ribociclib in the choice. Or if you have a visceral disease or impending visceral crisis, you have a right choice trial. It is conducted by our dear professor, Dr. Hamda Abazim. It's the main brain for this study. And we chaired as Ain Shams by 3 cases in this study to have ribociclib plus ovarian suppression plus AI in the patients progressed on tamoxifen for a second line for the patient with visceral crisis or impending visceral crisis. This is a design of the MONALEESA-7 trials dedicated for premenopausal women to give AI plus ribociclib as a first-line treatment after progression of tamoxifen. There is the significant OS benefit and BFS benefit, and this is a right choice design trial. You will take the time to have this design on the Google because it's a still pending trial because this trial conducted during COVID era, and we started giving the patients AI plus ribociclib plus LHRH analog versus the treatment choice physician chemotherapy. It was nevilbine capecitabine for all comers because in the COVID era we cannot give infusion for many patients. So RACHOS trial involving premenopausal patients progressed on tamoxifen to have a ribociclib plus AI plus LHRH analog as a second line treatment in the premenopausal women. And we can see that all the data with RACHOS trial are favoring give her LHRH plus AI plus ribociclib, even in the visceral crisis. I know this some sort of small percentage of patient, but with patient with visceral disease, with a rapidly progressing disease, if you're achieving a proper ovarian suppression and starting ribociclib plus AI, you can achieve response as chemotherapy. Because in many situations, in real practice, we cannot find the patient can't tolerate chemotherapy, especially patient with liver disease cannot tolerate taxanes because elevated liver enzymes. So it is a first highlight from RACHOS trial. We can see that patient receiving ribociclib plus AI plus LHRH are achieving much better than patient receiving chemotherapy after 1 year of follow-up. So second case, within 8 weeks, the patient have discharged from hospital, patient removing pigtail, and patient having a normal daily activity. And this is before treatment, and this is 12 weeks post-treatment. She has a marvelous effect after induction of AI plus ovarian suppression plus ribociclib. Second case is a pharmacist, 70 years old lady, de novo breast cancer. She was denying the breast mass over many years. She has CT chest showing bone mets with nodal and abdominal lymph nodes. She had symptoms, has severe pelvic pain, and actually, unfortunately, she presented to me with an wheelchair. She has ischemic heart disease and cardiac bradyarrhythmia controlled under pacemaker. Comorbid disease should be discussed with patients, and she actually did a cardiac consultation to have a mild AF under control of medications, and she has a chronic peptic ulcer controlled on PPI. What's the optimal CD46 for these patients? She was selecting ribociclib because she wanted the most significant OS benefit for her case. And actually, she have no contraindication to receive ribociclib. She received ribociclib, the treatment of choice, plus CI, and because of nausea, she at the same time take ondansetron for her vomiting. And unfortunately, few weeks after treatment, she have QTc prolongation more than 450 milliseconds. She has a bradyarrhythmia, and when we consulted clinical pharmacy, they told us that there is contraindication with ondansetron with ribociclib to have a comorbid bradyarrhythmia for this case. So when we revised the pharmacy, they omitted the ondansetron, but still arrhythmia is there and not controlled by any medication. That's why we stopped the ribociclib for those patients. And the message here, the prolongation of QTc interval occurs in the first 3 months of treatment. If you are not study your patients well, giving any medications, not study drug-drug interaction, you can miss your patient by a severe ventricular bradyarrhythmia, may be fatal for those patients. So you can see that ribociclib is a rich molecule. You have a contraindication with tamoxifen, and this arm is omitted in the MONALEESA trial to not give tamoxifen with ribociclib. You can give it with abema or palbociclib, and also any drug, or especially ondansetron, may induce bradyarrhythmia for the patient receiving ribociclib. So you should educate your patients about any alteration of the heart rate and any palpitation, and you should guide by ECG every now and then. So what's your decision for further treatment? Do you recommend abemaciclib or palbociclib for those patients? She stuck with abemaciclib because it has no affecting the heart rate, and she has no inflammatory bowel disease and no drug interaction for abemaciclib for her case. And you can see that diarrhea is the most common adverse events from abemaciclib. But actually, you can see the drug interaction between ribociclib and palbociclib. You can see that ribociclib and abemaciclib have a rich drug interaction, but ribociclib have 275 drug interaction with other drugs. So the message is, when giving ribociclib, we should study very well the drug interaction with ribociclib. The palbociclib and abemaciclib have no major drug interaction like ribociclib. So keeping with that from MONARCH 3 trial, she chose that abemaciclib may be appropriate for her. But actually, she had a diarrhea, and she has on wheelchair. You can imagine that a patient on wheelchair have a many bowel motion over day when bedridden. So the diarrhea is not a benign adverse events. It may be annoying and damaging quality of life for the patient receiving abemaciclib if you have no care or no care in the home for the patient who is bedridden or on wheelchair. That's why we stuck to the SOLANA trial. She saved us, and she go for AI alone, and we are waiting for progression to have CD46 plus fulvestrant if the patient not responding. It's more safe and comfort zone trial for those scenario. If you have a toxicity from CD46, you can keep on AI, and if you have a progression, you can use fulvestrant plus CD46 on the progression, and collectively, you have actually in the upfront AI plus CD46, you have PFS1 very good, but in the sequencing, shifting from the AI to fulvestrant plus AI, collectively, there is no difference between sequencing of the CD46 or to be second line or first line. The message from this trial is tell the same in some patients, CD46 as the same as a first line or second line treatment. So discussion of the patients is very important and comorbid illness, and there is no take the available drug. There is a high selectivity of CD46 between every patient. And what's further, as Dr. Hani said about the updates in ESMO updates, what's further, we have both CD46, we have a lot of data about to have keeping CD46 and to continue with another hormonal companion, or as maintain trial to continue with ribociclib plus after palbociclib. It's a phase 2 trials, but have significant BFS benefit with no OS benefit. And also, or to have mTOR pathway, a SOLAR trial and Bolero trial to give everolimus plus exemestane as a second line, or these trials to have a sequencing of treatment either fulvestrant plus AKT inhibitors, or to have ilcastrant as EMERALD trial for the patient having ESR1 mutations, or the patient have PIK3 mutation to have alpelisib plus AI. So it's about one trial, change of the AI, keeping the palbociclib, and change of the AI on the emerging ESR1 mutation. When those patients receive fulvestrant instead of AI and keeping palbociclib, they having a good response to treatment before progression of treatment, before progression of the meds. In the radiology, you can tracking the progression by tracking the ESR1 in the serum level. So my home message, although OS benefit is a gold and most reliable primary endpoint for many patients, but it should not be the only parameter to select CD46. Patient comorbidity, CD46 toxicity, drug-drug interaction should be taken into consideration. And also, you should study ribociclib precisely with interaction with ondansetron and tamoxifen. It's not allowed to give ribociclib with those drugs because a risk of prolongation of acute segment is high, and the risk of reticulocyte will be very high. And also, last message, updated data from trials, accurate clinical evaluation, deep knowledge of the patient comorbidities and toxicity, extensive knowledge of the adverse events. Oncology will be an art rather than job. Thank you.
Thank you, Professor Mohammed Sabri Al-Qadi, for your really excellent presentation. I have a comment on case number 2, because to add about what you said about toxicity as a selection criteria for CDK4/6 inhibitors, there is some emerging data about that the use of proton pump inhibitors, especially in the case number 2, is having peptic ulcer on proton pump. There is rising data that the use of proton pump with palbociclib may interfere with overall survival in patients with metastatic breast cancer. Yes, it is not an absolute contraindication yet, but it should be taken with caution. So I add to what you said about toxicity to be considered when we are selecting CDK4/6 inhibitor. So any question to Professor Mohammed Sabri Al-Qadi or any of the other speakers, Professor Hani and Professor Ahmed?
Dr. Sabri, thank you very much for your elegant presentation. My question about LHH antagonists. We don't have any data to use it in breast cancer. It's only in prostate cancer, I think.
Yes, it's no data, actually. It's my clinical experience only. No data with LHRH antagonist. But my vision in this case to have rapid ovarian suppression. I depends on the trial in the neoadjuvant setting to give LHRH antagonist to have much lower serum estradiol within 2 weeks in the neoadjuvant hormonal treatment in breast cancer. These data published for the neoadjuvant setting in the hormonal positive patient with breast cancer. I agree with you that safirmagon or LHR antagonist is not the drug of choice for many trials. All trials PALOMA and MOLASE and MARC trial using LHRH agonist to have ovarian suppression within 2 weeks. But in this case, because she was in a pending crisis, أنا اتهدت واديتها LHR antagonist to have a much lower serum estradiol level within 3 days as published in the neoadjuvant setting. In the neoadjuvant trial to have LHR antagonist plus serum plus CI. But still there, LHRH agonist is the standard of care and should be the standard of care to take in any premenopausal patients.
اتفضلي يا دكتورة هاجر.
دكتورة هاجر.
تكملة لكلام حضرتك as per protocol كل ال CDK4/6 metastatic.
دكتورة هاجر ممكن بس صوتك يعني.
هم as per protocol يا دكتور بكمل بس كلام حضرتك ان هو كلهم في ال as per protocol نفسه كل الثلاثة CDK4/6 inhibitors in the metastatic setting they كانوا بيعملوا سيريال للناس اللي بريمونوبوزال E2 و FSH كل شهر ونص لشهرين وكان في كلهم consistent data ان about 20% or less ما كانوش بيدخلوا في البوست مينوبوزال ليفل و they are considering as per protocol يا اما ان هو لو ما كانوش بياخدوا ال LHRH كل شهر يحولوا لكل شهر او الانتاجونست. ف it's considered.
دكتور هاني عبد العزيز أنا أشكرك علشان فكرتنا تاني بالأوليجوميتاستاتيك and I consider that ABC5 definition of oligometastatic is very reluctant and I hope they change it. So any new information in the ESMO before you comment on this احنا طول النهار في الام دي تي بنشوف ناس عندهم early breast cancer and then tiny pulmonary deposit or tiny pulmonary for follow-up. And this is tiny pulmonary lesion less than 2 or 3 millimeter. And I don't know in the post-COVID area this is oligometastatic or not. But actually we consider them as oligometastatic and then we treat and then it disappeared completely. Again, very tiny and 5 sites of oligometastatic. I mean the definition is very broad. Can you comment from ESMO?
Still, there is not settled. There is no clear, definite definition of oligometastatic. Regarding the very tiny pulmonaries which we face every day in our clinical practice, there is a many schedule and many tables to assess the risk to be metastatic or not, and most of these tiny nodules will be out of the score and considered as non-metastatic. But what I can conclude from the sessions in the ESMO, first, systemic treatment to be considered at first. If you have a local disease that you can ablate and you can control with local treatment, add. With the conditions they approved, 3 to 5 maximum metastasis, not more than 3 in one organ, you can control it or ablate it properly with SCBRT, and SCBRT is one of the most important tools. You can ablate it, and you can, of course, you can control the primary by the primary treatment, so you can go for treatment the case as an oligometastasis. There is a conflicting data because in the last ASCO 2022, there is another study whether to irradiate or not to irradiate the oligometastatic. Yes, the standard is to irradiate. Another debate about the brain with the appearance of the new anti-HER2, new effective anti-HER2, tucatinib and TLX2 in the metastatic patient. In the HER2, this is an exception. In the HER2, we can treat systemically and we may avoid local treatment.
Okay.
Turhani, going back to the oligometastasis, if you have a patient with solitary bone metastasis at presentation, would you treat this patient with curative intent or palliative intent?
For me, working in the field of breast cancer for many years, yes, I may consider, if I assess the risk, the generation of the patient, I may consider he as oligometastasis, solitary bone, because solitary bone, first bone metastasis is the best prognosis. Solitary lesion, relatively a good prognosis. Third, I can control it, I can ablate it by radiotherapy. Okay, so I will consider this patient for oligometastasis. This is my own experience.
I think, Dr. Hani, there is a conflict between the ESMO and the ASCO guidelines regarding the SBRT for oligometastatic disease. As you showed, the Sabrocomet trial was a basket trial. It included all solid tumors. It was not specific for breast.
I can't hear you, bro.
The Sabrocomet trial was a basket trial. It included many tumors, many types of tumor. It was positive, yes, but when they did a trial that specifically looked for breast cancer, the NRG trial, it was negative. So the specific trial for breast cancer is negative. That's why the ASCO guideline till now don't treat oligometastatic disease with stereotactic radiotherapy. I don't know why the ESMO guideline consider this. Based on what? We don't have a solid data to consider radiotherapy for oligometastatic disease.
I've mentioned 3 trials from the ESMO. The first one was for solid tumors, for all solid tumors, and the group of patients from breast were 18 patients, and the hazard risk was 0.77. 0.77 for those with breast subgroup analysis. Another 2 trials, including all solid tumors, and one of them were about breast cancer. And so in the ESMO guidelines, they didn't give you a strict or a direct instruction to do. Consider local treatment, consider the site of metastasis, consider the primary treatment first, and then consider local treatment SBRT for the metastasis.
I think it's an investigational point, and it needs further.
السلايد ان السب جروب اناليسيس بتاعت الاس اي بي ار تي ترايل الاولانيه كان في منها 18 بيشنت بريست والهازارد البروجريشن فري سرفايفل واوفر اول سرفايفل وذ البروجريشن فري سرفايفل هازارد ريشيو 0.77.
Yes, but you know we can depend on subgroup analysis. If we have a large phase 3 randomized trial, which is the NRG trial, all of the patients were breast cancer and it's negative.
I don't know there is a trial with a breast only.
You presented the NRG trial. Yeah.
Dr. Hani, I want to thank you about your elegant presentation, and actually Dr. Hani spent a lot of time to have, I be with him in the last ESMO. He spent a lot of time to have a good picture from the inside the ceremony.
Dr. Muhammad helped me so much بصراحة.
He did a good job and very hard work to have these slides. My input in the oligometastatic. You can irradiate whenever the patient needs or to have a local control, but this policy should not make us forget the systemic control.
Yes.
Because many practitioners are depending that the tumor is vanished by radiotherapy and forget about systemic control and give the patients adjuvant radiotherapy and adjuvant chemotherapy and forgot all about these issues. So I think the systemic control is the issue, and patients with oligometastatic bone disease are the excellent subgroup in the all trials of CD46 that achieving better overall survival benefit. So when you're lacking this vision of optimum systemic control, we may forget that the patient was metastatic.
Of course, this was not my presentation, of course, but they stressed on this point. I have mentioned the primary treatment, systemic treatment should be the primary. Systemic treatment, of course.
أنا أضم صوتي لصوتكم إن طبعًا إحنا عندنا عيانين كتير بيجوا ميتاستاتيك وبنevaluate according to the site of metastasis and the performance status and premenopausal status. and طبعا يا دكتور محمد ويا دكتور هاني لازم نبتدي systemic treatment. هقول لكم حاجة هي نكتة بس مش نكتة. أنا في الMDT بقول كمان بيبقى العيانة maybe a borderline of probability. فبنقول كمان إيه نيو ادجوفنت. يجي الدكتور عماد شاش مدير المستشفى يقول لي ما فيش حاجه اسمها نيو ادجوفنت يا دكتوره هبه في الميتاستاتيك. فاقول له طب بين قوسين انا اخترعت ترم اسمه سودو نيو ادجوفنت عشان اهرب من الدكتور عماد شاش. وكاني فور ذا بيشنت انتنت تو كيور. ايوه رد على الدكتور جمال الحسيني. ايوه patient intent to cure. I have many patients who presented with widespread bone metastasis. But they are still good condition and oligometastatic and they respond. المشكلة إن فعلا اللي بتقابلنا بعد كده they will receive local radiotherapy, but what else and for how long?
يا دكتورة هبة أنا ما بعترضش طبيا على، أنا بعمل كده في البرايفت إن جنرال، بس هو الفكرة إن هو
we have to discuss يعني.
لا هو عشان الفكرة إن هو قرار نفقة الدولة مش هيتوافق عليه، فهو في الآخر هو العيان مش هياخد الدواء اللي حضرتك هتكتبيه.
It's okay.
لا فيعني لكن لو عليا أديهم الدواء اللي هم هيعملوه.
طب دكتور عماد تكمله للسؤال، يعني انت لو جات لك الحاله اللي عندها ايزوليتد بون ميتاستاسيس هتبدا بكيمو از ستاندرد بالكيموثيرابي العادي؟ انا ماي سيلف اي دو ذات. I treat patient like any patient non-metastatic and I can consider CDK4/6 as adjuvant in this patient, although it's not included in the trials. But do you think this will be a proper management or you have different opinion?
دكتور جمال، هو احنا يعني لازم نتفق ان هو في a lot of gray zones موجودة عندنا، فيعني what I will consider oligometastatic is to be treated from my point of view as a curative intent. بس oligometastatic which kind of which not liver which level، وكمان oligometastatic of a known good biology. يعني ال HER2 positive oligometastatic مختلف عن الluminal oligometastatic. ف that's again another point. What we will do ان هو neoadjuvant محدش هيختلف ان هو we will do the best for the patient. But however the guidelines اللي موجودة وبيتصرف عليها الأدوية بالذات في اللي هو ال HER2 positive ان هو dual blockade، لو في metastatic site then dual blockade will not be reimbursed للpatient، فعشان كده مش هنقدر ان احنا ندي ال dual blockade. فبالتالي العيانة will be actually أنا عاوز إن هي تاخد at least ال anti hair therapy. Yes it will be neoadjuvant, she will receive اللي هو ال anti hair therapy أحسن من ما فيش، يعني أحسن من ال dual blockade هيبقى من اللي أنا ما اديتهوش عشان هو العيانة considered metastatic، فبنقول إن هي تاخد trastuzumab. لكن ما ينفعش يا فندم إن أنا يعني أعقب على قرار طبي، ولكن دوري ان انا احط الكونتكست بس اللي موجود بس يعني.
هو بس لو هسأل سؤال صغير يا دكتور هبه ودكتور عماد، ان هو مع حضرتك تماما ان هو يعني to be considered the site of metastasis in biology due to be considered well ال HER2 positive very good يعني responders، وفي exceptional responders هم دول اللي بعد even some response I will consider local treatment. السؤال بقى في ال HER2 negative hormonal receptor positive to start زي ما دكتور جمال قال الكيموثيرابي with the intention of the curative intent, then surgery and local radiotherapy, or to go first as a metastatic line CDK4/6. يعني ده لاين وده لاين تماما خالص. الHER2 بنقف في النص واللي هو الHER2 ناخد الهرسبتين والكلام ده، انما اليومينال وسنجل ميتاستاسيس we will consider neoadjuvant chemo.
I treated radically like any patient non-metastatic, and I can consider in the adjuvant setting with hormones to adding CDK4/6. Although this is not the standard, but I have some patients for many years are doing that, and this is not a standard of care, I know, but I asked many oncologists abroad also, and most of them agree that patient with solitary bone metastasis, this patient carries a very excellent prognosis. So treating as a non-metastatic disease may be logic. There is no standard of care, of course, with this case. It's the same like in prostate cancer, the same is equal.
And for me, Dr. Hagar, if the patient is luminal A, she is premenopausal or postmenopausal with KI 67 less than 20, I start with aromatase inhibitor, ovarian suppression if she is premenopausal, and CDK4/6 inhibitor. Like endocrinal, you can say it neoadjuvant, adjuvant, or treatment. And I have many patients who is responding in maybe in luminal B, the gray zone is still there, and we can use chemotherapy as well.
If I have a final comment, in spite of all guidelines, in spite of all studies, we should consider every patient by patient. We should discuss every patient in the MDT. Can I apply this data on such patient or not? Can I give certain protocol for this patient, and maybe the patient for the next day or the next one, I cannot. So we can individualize. My last comment about the ESMO, that we are going into the era of molecular biology, especially in the triple negative, using the artificial intelligence. For example, you are not going to give later on, in the coming few years, maybe, you are not going to give PARP inhibitors upon that the patient have germ BRCA prime mutation only. But there's a lot of data, very complex data, will be entered on the computer using machine learning and artificial intelligence, and the machine, the system, the computer will tell you this patient will get benefit or PARP inhibitors, for example, or not. This is the future that I can sense. This is the future of the treatments that we personalize, even in the immunotherapy. They are seeking for personalized immunotherapy for such a patient, not for triple negative, for example. Thank you.
My comment, if a patient is having luminal, as Dr. Hagar said, what is the value of giving aggressive chemotherapy as neoadjuvant and then doing surgery and local radiotherapy in absence of survival outcome in a patient with oligometastatic bony lesion, for example, and this lesion may disappear with the use of first-line metastatic hormonal-based with CDK4/6 inhibitor. What is the aim of treatment? I mean, is there any survival difference? Yeah, we do not have evidence for justifying aggressive chemo in the neoadjuvant and then surgery with its complications and then local radiotherapy. If we have single bony lesion and we started with CDK4/6 hormonal and the bony lesion disappeared, as we say all in clinical practice after first line treatment. I think the issue may be solved if CDK4/6 inhibitors are approved in the neoadjuvant setting, because at that case, as Dr. Ahmad said, in HER2 positive, we will have the same. We will receive neoadjuvant hormonal CDK4/6 if it is approved as the first line metastatic. So the patient will not lose a toxicity of chemo, surgery, and so on.
Need brainstorming, and as Dr. Hani said, it's case by case cases. I have a case in 2012. A young lady who is 35 years old came to my clinic with a solitary disease patient, solitary bone metastasis, proved by pathology to be metastatic. I offered her radical treatment, and this patient went to MD Anderson, and also they offered her radical treatment, even mastectomy, and the patient is still alive. This doesn't mean you have applied this to all patients, but we have to discuss with the patient, because the survival, if it treated as non-metastatic, survival of non-metastatic is much higher, even with CD4/6. And this patient, if we treat with curative intent, she will go to have a mastectomy or whatever surgery and local regional radiation as well. This is not the standard, I know, but think about it. I don't have that. We have data now, for example, in prostate cancer, you treat radical in patients with oligometastasis. This was not the case years ago.
And just to remind that we have among 6 trials, only 1 trial showing overall survival with local treatment, which is the Turkish one. The Turkish trial showing overall survival when adding local treatment in metastatic patients.
Any other questions? Okay, if no, I would thank all the speakers, all the chairpersons, all the attendees, and I thank you all, and I close the session.